Thank you, Vance. No, I'm good. You give it to Steve Gable. All right, so on a counterpoint to that, we're going to talk about FUE anesthesia. And it all begins with understanding of anatomy. You heard a great lecture from Steve this morning. I really don't need to repeat too much of it. But as we continue through this lecture, I'm going to repeat some of those salient points. That supraorbital nerve does go all the way back toward the top of the crown, but doesn't hit the whole thing, so it covers quite a bit. But there are these small branches that come up from the side, and then from the donor capacity, where we're talking about the anesthesia for the donor area, there are these occipital branches that come up, and we want to try to anesthetize the patient in a way that minimizes pain for them and maximizes longevity. Don't worry about copying this down. You're going to get a copy of this. So for FU, I have a Joint Commission accredited facility, so my patients also have all the advanced care treatments, ACLS, et cetera, all the things that we need to treat them for. Even if you don't have an accredited facility, you need to be able to be prepared for any problems. I do use some Versed for FUT. They can go deeper, but I found that with FUE, since they're down in a prone position, I don't want them as sedated, but I do want them pretty sedated so they're comfortable, because it's a long procedure. So this is my regimen that I use for sedation. I don't always follow this recipe of sequence, but in general I do this. We first get the patient prepared. I draw the hairline, get the patient ready to have the procedure, draw the PRP. You want to draw the PRP before they actually get any injections, because the PRP is supposedly the most active when there's no trauma to the body. I undergo some sedation. I start by anesthetizing the recipient area, then the donor area, making my recipient sites, which plans what I'm going to do for my donor area. And I harvest the grafts as my staff is extracting it, and then the patient's prepared, reinforced on the front with more recipient anesthesia. PRP is injected, and then the grafts are placed. So again, these complicated formulas are given to you. The nuts and bolts of this is that since my FUT patients are under deeper level sedation, I just perform a ring block, put in the tumescence in the back, whereas with FUE, I'm not really totally doing a ring block. I'm really relying on the tumescence to provide anesthesia, which will be clear as I present this information. And that marcaine that's in the FUE donor tumescence is really the kicker to make this last a lot longer. A colleague of mine here in St. Louis has really changed my thinking about tumescence as well, that tumescence has just this different quality that allows it to last so much longer than regular anesthesia. So for me, the cornerstone of this whole lecture is the tumescence. That is what provides the prolonged anesthesia, even if you're not doing it to have a tumescent effect. Sometimes in FUE, the tumescent effect is not indicated, but even the machines that say not to use tumescence, I still, in my hands, feel better with the tumescence. But the tumescent block allows you to have a much more prolonged anesthesia in my hands. So the patient's under lighter sedation, so instead of just doing a ring block, I do it staged. I use a vibration device. I use this 32 gauge needle with 1% lidocaine. I'm just placing little blebs around the front. I reinforce it with 4% septicaine. This is really nice because it holds for about 3 to 4 hours. Usually in the middle of the harvest or toward the end of the harvest, I have an Alexa remind me that, hey, I need to reinforce it with marcaine so that you don't let the septicaine wear off. The reason septicaine is nice because it provides more prolonged anesthesia and there's less discomfort during the injection process. Then I inject some recipient tumescence just to get some hemostasis. And then on the back side, I'm repeating this. I'm just putting a few points of the 1% lidocaine with a 32 gauge. But at this point, I actually, sometimes I join these sites. Sometimes today I don't even join these sites now. I just skip this step. And I have the tumescence that has a dilute marcaine in it. I use a 26 gauge needle and I inject from the occipital nerves. Remember that there's these branch of occipital nerves going up. There's the main trunk here, and then the lesser ones lower down. And then you've got these side branches coming up, which we'll discuss in a moment as I go over there. But we're just injecting up. So if you go from the mastoid prominence, which is where the line is, and sort of bleed it up a little bit at the lateral points where the mastoid is, you're going to get the main trunks. And then I just, from that point, go down and then inject and finish the whole area. So once you've got this, they're pretty numb except for the contribution of the auriculotemporal and zygomaticotemporal laterally. But I'll tell you how to do that so they're not so much uncomfortable when you go laterally. So I just finish the block going upwards. This is that tumescence again with dilute marcaine. And then as I finish and complete that, I go laterally. And what's interesting is that even though there's these two branches I just mentioned going up laterally, if you progress from the occipital nerve and go laterally, they don't feel very much. You can go all the way out there, but you need to do that to capture those two additional nerves that go up. Again, auriculotemporal, zygomaticotemporal. But they're already pretty numb as you go laterally with this technique. So this is a technique to minimize discomfort for the patient. As I was mentioning to you, I have a timer that tells me, hey, it's about 3 hours. Let's go ahead and put the marcaine in so that in the front before it wears off, because even though marcaine has a really good benefit, which is long lasting, the biggest negative with marcaine is that it stings a lot. So you want to really put this in before the septicaine is fading off. I had a gentleman just a couple days ago that I did a FUT procedure on, where I was reinforcing the ring block with some marcaine. He could feel it, so I stopped, put a little lidocaine, he could feel it, and I realized, you know what? He is just not blockable easily with a ring block, so I went straight to the supraorbital block. So the supraorbital block is not only something that you may consider as an alternative to do, but it could be something if there's a situation where you're not getting adequate anesthesia or it's not lasting. I have some patients where I put the ring block in and it's just not lasting. I'm placing it more superficially, trying to capture the midline where there's redundancy. I can't get that long-term anesthesia. Go straight to the block. And for that, septicaine is awesome because it burns very little. It lasts about 3 hours. And again, I have that Alexa timer telling me, hey, if 3 hours are up, go ahead and start putting the marcaine in if I need that level of longevity. Otherwise, I may just do another septicaine block for him. So here's a schematic. I think it's always easier to see a schematic diagram of this. So this is FUE anesthesia. I put step by step. I just place the little punctate blocks with the 1% lidocaine. This is just so that they don't feel my tumescence going in, my larger needles with that going in. I connect the dots, but I don't always do that. I start the block from this lateral point where the greater occipital nerve is maximal, and I do it on the other side as well. And then I start joining those together so that block is there, and then I start to expand it across this zone, and then I start to bring it upwards as I was mentioning, and I start to go laterally with it. And that's basically the technique. Again, you're going to get these slides. This technique actually works really well for beard as well, because beard is also this regional blockade that it's very hard to anesthetize if you try to do a ring block on it. It just doesn't work, and it doesn't last. So I don't even bother to ring block this out. It's just not feasible in my hands. So I put a little bit of a bleb of lidocaine with 32 gauge needles so they don't feel it, use some vibration device, and I just start going medially with this tumescence that has the dilute marcaine in it, and just go straight across there. So that's very, very effective. And I thought I just would go ahead and put in a similar scenario, which is the beard recipient area if you're doing a beard transplant. Although we're going to have a great talk. I think Bob is going to give a talk on this. What I do for the midline, anything medial to the oral commissure, if they've got some areas I've got to work on, I go ahead and put, I actually start with 3% carbocaine plain, just so it doesn't burn, about a quarter carpule per quadrant. If you don't know how to inject this, it's very simple. It's the third root. You go from unattached gingiva and just bend it down to attached gingiva, and you do the same thing on the bottom. It's between the fourth and fifth root, so it's my mnemonic is 3, 4, 5, and you just go from unattached so they don't hurt, touch down to periosteum. They're totally numb. You do not need to go infraorbital blocks and all that business. And the septicaine provides a really nice painless anesthesia that lasts several hours in this area. But anything lateral to the oral commissure, it actually just starts maybe about a centimeter medial, you're not going to get anesthesia lateral to that. So you need to do the same blockade in this with the tumescence. So you see the same thing. I inject with this little lidocaine bleb, and then I just expand that bleb going across with the same dilute marcaine. The one thing is this area takes a little bit more anesthetic than you usually think, because there's so much confluence of all these different cervical branches coming up here laterally. So I just put this up there just to remind you that it is good to use the Alexa, Siri, whatever, to remind you. It's a great thing. I have that in the room playing. Of course, if you have privacy issues and worried about it, don't do it. But it's my way of keeping track of my anesthetic times during the day. So a few tricks. I'm very focused on patient pain control. The gate theory of pain to me is huge, which essentially means if you have pain going up to the brain, but you can stimulate it with some other vibration or something else going on, your brain gets a busy signal and can't feel the pain. So I really try to help my patients not feel pain. I'm vibrating with my fingers. There's a vibration device next to the patient. All these different techniques are used so the patient does not feel much discomfort. Of course, sedation is huge. One, to reduce the pain, but also to make the procedure bearable. I always say instead of flying to London in economy class is like flying to New York. It's a shorter feeling. It doesn't feel as long. And the patient is not so fidgety. And so I think that's so important both for FUE and FUT. And as I mentioned before, I do a slightly deeper sedation with FUT because of their positioning is a little bit more accommodating for that. Progressive anesthesia is the next principle. What that essentially means, as I told you, is start from the point. If you know the nerve anatomy, you've got to know the nerve anatomy. Start from the block, start with a small gauge needle, small area, progressively use this moving out from the different nerves that I told you about. Again, you'll have all those. And if you know the nerve anatomy, you understand how to leverage that in your favor. And then the other thing, as I was mentioning, just to put that salient point up, is that bupivacaine tumescence, that dilute bupivacaine tumescence serves so much of a great function for me, not just for FUT harvesting, which is awesome, but in terms of just tumescence, I don't even use the marcaine there, but because I go back and reinforce with a ring block for the patient. But when I'm dealing with this diffuse FUE area I've got to harvest versus just a linear strip, I've got to anesthetize a wide area for a very long period of time. Same thing when I'm looking at beards, beard recipient and beard harvest zones. I've got to have an area that is very complex nerve-wise, very hard to yield long-term anesthesia in a painless way. And so my workhorse is a dilute bupivacaine tumescence. So I thank you for your attention. We are ahead of schedule. Are there any questions?